The National Conference for Nurse Practitioners Fall Virtual Conference is only a month away. The event will take place from October 21st to 24th from the comfort of your own home. Register today to have access to sessions that are for nurse practitioners presented by nurse practitioners. The sessions will cover diverse topics and current issues, including best practices during the COVID-19 pandemic. You will have the opportunity to earn up to 55 CE credits and up to 36 advanced pharmacology hours. If you are not able to attend during the event, you will have access to the session recordings for up to 90 days after the conference. For more information, please visit us at ncnpconference.com. In this episode of the Nurse Practitioner Podcast, Dr. Julia Rogers and Dr. Jodi Allen discuss the top 2 billable endocrine disorders in primary care: type 2 diabetes mellitus and hypothyroidism. What is the significance of understanding the pathophysiology of endocrine disorders?
It is important for nurse practitioners to have a clear understanding of the initiation and progression of disease in order to understand the why. Why are certain clinical manifestations present? Why are specific diagnostic tests ordered? And why treatments are chosen for certain disease processes.
It is important to have a breadth and depth of the pathophysiology of endocrine disorders because they are interwoven. For example, the pathogenesis of the 2 endocrine disorders we will discuss today, diabetes and hypothyroidism, both are initiated from a disturbance within the endocrine glands. Hypothyroidism is due to a disturbance within the thyroid gland, and diabetes from a disturbance in the islet cells within the pancreas. These cells in the pancreas control the release of the hormones insulin and glucagon, which initiates insulin resistance. Overall, understanding the pathophysiology means appreciating the cascade of events that happen when the body causing a reactive process to unfold. For example, a change in one hormone level can throw off another.
While there are similarities in the pathophysiology of disease processes, what are the inherent differences between diabetes and hypothyroidism?
The endocrine system is a network of glands that produce and release hormones that help control many important body functions, including the body's ability to change calories into energy that powers the cells and organs. The disruption of homeostasis within the endocrine system influences whether or not you develop diabetes or thyroid disease. Each gland of the endocrine system releases specific hormones into your bloodstream. These hormones then travel through your blood to other cells and help control or coordinate many body processes. Even the slightest hiccup with the function of one or more of these glands can throw off the delicate balance of hormones in your body and lead to an endocrine disorder. Hypothyroidism is generally the result of a deficiency in thyroid hormones, T4 and T3, but can also occur from a defect along the hypothalamic pituitary axis. In this case, the pituitary gland fails to synthesize adequate amounts of TSH or a lack of TRH and is considered central hypothyroidism, which can be congenital or familial due to a genetic defect. The most common cause of primary hypothyroidism is Hashimoto thyroiditis, which is caused by an inflammatory process that destroys thyroid tissue in genetically predisposed individuals through the infiltration of thyroid autoantibodies, autoreactive T lymphocytes, natural killer cells, inflammatory cytokines, and induction of apoptosis. Because Hashimoto disease is an autoimmune disease, it is linked with autoimmune conditions such as diabetes type 1, Addison's disease, pernicious anemia, myasthenia gravis, celiac disease, rheumatoid arthritis, and systemic lupus erythematosus.
Diabetes mellitus, specifically type 2, is a result of a substandard response of insulin-sensitive tissues, particularly liver, muscle, and adipose tissue to insulin. As insulin resistance increases, insulin levels rise, but the glucose level will remain essentially normal, resulting in a state of hyperglycemia. Prolonged hyperglycemia promotes destruction of pancreatic beta cells, which produces fasting hyperglycemia as hepatic gluconeogenesis increases secondary to glucagon production. As glucagon concentrations increase in diabetes, glucose inhibition by the pancreatic alpha cells is impeded, further increasing secretion of glucagon. As hyperglycemia persists, further beta cell destruction is imminent, and over time, hypoinsulinemia worsens. Obesity is linked to induction of insulin resistance and beta cell dysfunction secondary to pro-inflammatory cytokines. Other conditions such as non-alcoholic fatty liver disease, atherosclerosis, and dyslipidemia have the same effect. Incretin hormones located in the gut, glucagon-like peptide 1, or GLP-1 specifically, are deficient in diabetes mellitus type 2, limiting the natural ability of glucagon inhibition secretion postprandially. Without appropriate gut hormone response, the satiating effects of insulin are unable to be produced, causing appetite dysregulation and weight gain, which can further exacerbate diabetes and its complications. A pathophysiologic reaction to hyperglycemia is for the kidneys to absorb more glucose, leading to renal, microvascular damage, and significant renal complications. An important note regarding the sequence of the pathophysiologic mechanisms causing diabetes mellitus type 2 is that they tend to occur jointly rather than sequentially. Although insulin resistance is insufficient to independently cause diabetes, it is the strongest predictor of its development and the primer for the cascade of negative health effects associated with this diagnosis.
Explain how the clinical manifestations of diabetes and hypothyroidism relate to each other and are tied to the pathophysiology of the disease.
The signs and symptoms for hypothyroidism and diabetes are relatable back to the pathophysiologic process of each disease. The endocrine's feedback system helps control the balance of hormones in the bloodstream. If your body has too much or too little of a certain hormone, the feedback system signals the proper gland or glands to correct the problem. A hormone imbalance may occur if this feedback system has trouble keeping the right level of hormones in the bloodstream, or if your body doesn't clear them out of the bloodstream properly. The clinical manifestations in hypothyroidism are caused by a decrease in the thyroid hormone level, which lowers energy metabolism, heat production, and causes diastolic hypertension. This causes symptoms of increased fatigue, lethargy, weight gain, bradycardia, dysphagia, constipation, oligomenorrhea, cold intolerance, and a decreased body temperature. Patients can also complain of thinning coarse hair and, upon examination, have decreased deep tendon reflexes. The decrease in the level of thyroid hormone can lead to excessive TSH production, which then stimulates thyroid tissue, and this is what causes a goiter. Associated laboratory findings associated with the pathophysiologic process involved in hypothyroidism includes hyponatremia, hypoglycemia, anemia, increased lipoprotein cholesterol, increased liver enzymes, and an increased creatinine kinase, all of which reflect that hypofunctioning of the body systems. Some of the similarities of endocrine disorders is a patient that has a family history of endocrine disorder.
Due to the metabolic abnormalities caused by both disease processes, you will see clinical manifestations that reflect this. Fatigue and weight gain are common subjective complaints with both disease processes. Diagnostically, hypothyroidism and diabetes mellitus type 2 often coexist. For example, an NP may perform laboratory studies on patients with a diagnosis of hypothyroidism and discover an underlying diabetes and vice versa. The clinical manifestations in diabetes are caused by insulin resistance and subsequent destruction of beta cells due to prolonged hyperglycemia. However, this is insidious and often unnoticed until the insulin resistance is extreme and severe comorbid conditions are present. The need for screening of clinical manifestations is imperative to early detection of the disease, early intervention, and avoidance of micro and macrovascular complications. If symptoms do exist, they are classically the 3 Ps, polydipsia, polyuria, and polyphagia, but fatigue, pruritus, numbness, tingling, or blurry vision can be present as well. Persistent vaginal candidiasis in women and slow wound healing, chest pain, or headaches in all patient populations can uncover an underlying diagnosis of diabetes mellitus type 2. Laboratory findings associated with the pathophysiologic process involved in type 2 diabetes include hyperglycemia, dyslipidemia, increased liver enzymes, increased creatinine kinase, microalbuminuria, and decreased glomerular filtration rate, all which also reflect the hypofunctioning of body systems.
Discuss how the treatment for endocrine disorders is related to the pathophysiology of the disease.
Treatment of endocrine disorders can be complicated, as a change in one hormone level can throw off another. Treatment for hypothyroidism is intended to decrease the serum TSH and increase serum T4 to normal levels. A synthetic thyroxine, known as the medication levothyroxine, is the most widely used treatment for hypothyroidism. Dose adjustments are made according to the TSH lab values every 4 to 8 weeks. If the patient has a significant change in weight, a TSH should be done earlier. The initiation of synthetic replacement has the potential to exacerbate adrenal insufficiency in patients with severe hypothyroidism. Therefore, to avoid worsening adrenal hypofunctionality, patients should receive appropriate doses of glucocorticoids until the adrenal insufficiency is ruled out. Synthetic thyroxine, such as levothyroxine, needs to be taken 1 hour before breakfast or at bedtime 4 hours after the last meal, on an empty stomach and with water. The patient should be instructed to wait at least an hour before consuming other medications or foods. Patients need to avoid medications that interfere with the levothyroxine's metabolism, such as antacids, iron sulfate, and proton pump inhibitors.
The treatment of diabetes mellitus type 2 is complex, requiring ongoing office visits, education, and the use of chronic medications to prevent acute and chronic complications. Both non-pharmacologic and pharmacologic treatments may be necessary. Lifestyle modifications are the principal treatment modalities, both initially at diagnosis and throughout the disease process. These include maintaining optimal weight, increasing physical activity, ensuring adequate sleep, behavioral therapy, and smoking cessation as necessary. Due to the variety of pathophysiological mechanisms involved in diabetes, there is a plethora of pharmacological therapies to combat it. Current therapy is based on a step approach centered around the patient's glycosylated hemoglobin results. Therapy includes drugs that alter insulin action, stimulate insulin secretion, affect the absorption of glucose, mimic the effects of incretin, act as an insulin secretor, or suppress postprandial glucagon release. Metformin is a biguanide we are all familiar with that is effective in decreasing hepatic glucose production and intestinal absorption of glucose, while also increasing insulin sensitivity in peripheral tissues. It is well known as first-line pharmacological therapy for diabetes mellitus type 2 by both the AACE and ADA, but is not without contraindications and risks that require careful analysis. Both AACE and ADA guidelines include use of GLP-1 receptor agonists, SGLT2 inhibitors, DDP4 inhibitors, TZDs, alpha-glucose inhibitors, sulfonylureas, and insulin for effective mono, if indicated, dual and triple therapy of diabetes mellitus type 2. AACE and ADA guidelines are specific to starting with metformin as monotherapy, unless contraindicated, when the entry-level A1C is less than 7.5%. An entry-level A1C of 7.5% or greater requires dual or triple therapy with metformin, again, unless contraindicated, along with another agent as previously mentioned, such as a GLP-1 or DDP4 inhibitor. An entry-level A1C of greater than 9%, especially if a patient is symptomatic, requires insulin, often basal, in addition to other agents as previously mentioned. Being cognizant of the risks, benefits, and contraindications of each type of pharmacological intervention are key in developing a patient-centered plan that will promote adherence.
Diabetes and hypothyroidism disorders are in the top 12 list of diagnoses billed in primary care. So can you speak a little bit about billing for these disorders?
The ICD-10 code is a morbidity classification published by a joint effort between the CMS and the National Center for Health Statistics. The ICD-10 is the standard billing code system that is used to submit diagnosis codes for insurance reimbursement. The code with the highest specificity will increase reimbursement. The E codes are associated with endocrine disorders, and for hypothyroidism, the codes span from E00 to E07. Coding specificity includes reporting all diagnosis codes that identify a person's condition. In understanding the ICD-10 coding system, an other code means that while there are codes for hypothyroidism or diabetes, there is not one for the patient's specific condition. Whereas an unspecified code means that the condition is unknown at the time of coding. In this instance, hypothyroidism unspecified E03.9 may be used and then coded more specifically at a later visit. For example, if the patient has hypothyroidism that is unknown, then the code E03.9 would be used. However, if the cause of the patient's hypothyroidism is known, but is not one of the existing codes, then use code E03.8.
ICD-10 codes for diabetes mellitus type 2 are composite codes that express the type of diabetes, the body system affected, and the complications affecting that body system. The current coding expectations are to use as many codes as necessary to identify all of the associated conditions and adequately describe all complications of the disease. The ICD-10 code E11, which is specific for diabetes mellitus type 2, is submitted for individuals that do not present with known disease-related complications. To represent the highest level of specificity in coding, subcategories are assigned. For example, if a patient has type 2 diabetes with diabetic chronic kidney disease, then you would submit code E11.22. If a patient has type 2 diabetes with a foot ulcer, then you would submit code E11.621. Supportive information within the chart will provide justification for highly specified and correct coding.
While it is not uncommon for patients that have long-standing endocrine disorders such as hypothyroidism or diabetes to develop other physiologic conditions, it is important to document the supportive information within the chart. It is equally imperative for the NP to code correctly.
What is the nurse practitioner's role in managing endocrine disorders?
The role of the nurse practitioner includes implementing a collaborative approach to care and managing the primary, secondary, and tertiary preventative care of patients with endocrine disorders. Overall, the NP role includes the initial and ongoing assessment, ordering of labs and diagnostic testing, pharmacologic and non-pharmacological management per treatment guidelines, patient education, coordination of care, including referrals, follow-up, and billing services for reimbursement of care and performance measurement.
Nurse practitioners are an integral part of a team-based approach to care, which contributes to improved patient outcomes. NPs help increase follow-up opportunities and maintain a judicious focus on cost-effective treatment. Patient satisfaction with a specified treatment plan and quality of contact with a healthcare professional is linked to medication adherence and compliance with lifestyle behavioral changes. NPs see beyond the diagnosis and follow a more holistic approach to care. An NP considers the social, cultural, economic, and behavioral elements of an individual with endocrine disorders and designs a patient-specific treatment plan by being culturally sensitive, examining guidelines, and addressing any relevant social determinants of health. This is just one of the many ways NPs are leading the way to promote change within communities and improve the quality of care gap and ethnic disparities.
This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer.